Status asthmaticus is otherwise called acute severe asthma. Severe obstruction persisting for days to weeks. Acute severe asthma treatment. Best initial treatment, a high concentration of oxygen. Short-acting inhaled beta-2 agonist, albuterol, perbuterol, levelbuterol. Bolus dose of steroid. So oxygen, a beta-2 agonist, and steroid. If the above treatment does not work, then do the following. Slow infusion of aminophylline, magnesium sulfate given intravenously. These patients may benefit from an anesthetic such as halothane. If they have not responded to conventional bronchodilators, give halothane. Sedatives should never be given as they may depress the ventilation. Antibiotics should not be used routinely unless there is a sign of pneumonia. Important point is that in severe acute asthma, sedative and Montelukast are not given. Tiotropium bromide is used in COPD. So once again, best initial treatment is going to be oxygen, beta-2 agonist, and steroid. Oxygen, beta-2 agonist, steroid. Just remember BOS, okay? B is beta-2 agonist, O is oxygen, S is steroid. So like immediately the best initial treatment is going to be BOS. Ask the boss for help. BOS is B is beta-2 agonist, O is oxygen, S is steroid. If that boss does not work only, you want to go for aminophylline, magnesium sulfate, halothane, sedatives. No. Okay. So next we do aminophylline and magnesium sulfate. If uh, if still it does not work, then you can give halothane. You should not give sedative. Should no need to give antibiotic for asthma unless there is pneumonia. New drugs have come. Anti-IgE monoclonal antibody omalizumab. It is a new drug used in highly selected patients with persistent allergic asthma. It is a IgE blocker. Magnesium sulfate is used in severe asthma. Bambuterol, it is a very long-acting beta adrenoreceptor agonist and is used in treatment of asthma. It also is a prodrug of terbutaline. Bambuterol is a long-acting beta agonist used in treatment of asthma. Terbutaline. Anti-IgE is omalizumab, magnesium sulfate, bambuterol. Omalizumab, magnesium sulfate, bambuterol, they are saying these are all new drugs. Corticosteroid resistant asthma is defined as failure to respond to a high dose of oral prednisolone of 40 mg OD for 2 weeks. Whenever we are looking at a beta agonist, the response is expected within 15 minutes. But when we are talking about steroids, the response have to be measured against, we are looking at a time frame of 2 weeks or 4 weeks. So if a high dose prednisolone is given, that is 40 mg prednisolone is given OD for a period of 2 weeks and there is no there is no improvement, then we know there is corticosteroid resistance. COX-2 inhibitors are safe in asthma. Cigarette smoking, there is evidence that smoking interferes with the anti-inflammatory action of corticosteroids. Anticholinergic drugs like ipratropium are less effective in asthma. They're more effective in COPD. So, which is why they always say in COPD, if beta agonist isn't working, you might want to give an anticholinergic drug, antimuscarinic drug. But for asthma, if beta agonist is not working, you might want to give a steroid. All asthma patients should be given influenza pneumococcal vaccination. Refractory asthma treatment. Definition: asthma which is difficult to control is called refractory asthma, just like a childhood definition. Classic. Low dose theophylline may be helpful in some patients. Theophylline withdrawal have been found to worsen in many patients. So theophylline is the gold standard for this. For refractory asthma, remember TR. Theophylline is for refractory asthma. Most of the patients require maintenance therapy with oral corticosteroids. Steroid sparing therapies are rarely effective, so you always want to give theophylline and steroids. Low dose theophylline and oral steroids. Omalizumab is effective particularly when there is frequent exacerbation. And few patients may benefit with infusions of beta-2 agonist. Okay, I think it's done. We saw status asthmaticus. Thank you.